My name is Marina Stasenko. I am a GYN oncologist at NYU, and I'm going to give everyone a bit of an overview on cancer and menopause. So, briefly, we'll talk about chemotherapy, we'll talk about radiation therapy, we'll talk about hormones and anti-hormonal therapy. I will cover the three main GYN malignancies of ovarian, uterine, and cervical cancers and how they both cause menopause and affect menopause. I will briefly cover breast cancer and then a little bit about other cancers as well. So, cancer treatment and menopause. Cancer treatment can lead to menopause in several different ways. Surgery, for example, some cancers require the removal of ovaries. Chemotherapy. Chemotherapy itself can lead to early ovarian failure. Anti-hormonal therapy, as some cancers are specifically affected by estrogen. And so we use anti-hormonal therapy to treat these cancers. And radiation therapy that's similar to chemotherapy can cause early ovarian failure. So chemotherapy, let's talk about that specifically. Chemotherapy can stop ovaries from functioning properly. This can be temporary or it can be permanent. The most common chemotherapies used for GYN cancers are carboplatin and paclitaxel. And the most common chemotherapies used for breast cancer are adriamycin, carboplatin, cyclophosphamide, and paclitaxel. And while all chemotherapy agents can lead to early menopause, some are more likely. And interestingly, these are alkylating agents like cyclophosphamide and taxanes like paclitaxel. Hence, both breast and GYN cancers often see premature menopause as part of their treatment, as a result of the treatment. Risk factors for premature menopause include being older or closer to menopause, having fewer oocytes or eggs, and receiving higher doses of chemotherapy. There was one interesting study that looked at whether AMH or anti-Müllerian hormone can predict the likelihood of induced menopause. And basically, this was a study that looked at premenopausal women between the ages of 18 and 45, and they were planned to undergo chemotherapy with curative intent for either breast or hematologic cancers. These patients had a few hormone levels checked, including AMH, FSH, LH, and estradiol level. And these were checked before, during, and following the completion of their therapy. AMH is a hormone produced by granulosa cells and can correlate with ovarian reserve. In some studies, it's been shown to be useful in predicting the age of menopause in premenopausal women to somewhat of an accuracy of about 6 months or so. It is important to note that it is not routinely used for to diagnose menopause, but at least it has been shown that it can correlate. So in our study in particular, these patients, basically menstrual status, menopausal symptoms, and quality of life data was looked at. It's a relatively small study, about 22 people, but interestingly, the baseline AMH of women who regained menses post-menopause was higher than women who did not regain menopause. And this the difference was significant at about a year following diagnosis. So it's not necessarily something we use routinely, but it is an interesting finding and may be helpful to help guide a patient to what she can expect following her treatment. Radiation. Radiation to the pelvis is treatment for various cancers. In the GYN world, it's predominantly used for cervical and vaginal cancers, but it can also be used for lymphoma, some sarcomas, and anal rectal cancer. Radiation can cause ovaries to entirely shut down. At a dose of 2 gray, this results at a 50% oocyte destruction. And a dose of 14 gray results in ovarian failure in nearly all patients. And just to give you kind of a gauge to what we use for treatment, the treatment dose for cervical cancer can be 45 gray or higher. So almost guaranteed that if an ovary sees that dose of radiation, it will result in ovarian failure. Ovarian transposition. So this is the physical movement of ovaries from the lower pelvis up to the upper pelvis above the pubic or above the pelvic brim. The idea of this is to help keep the ovaries out of the intended treatment area. And this has about a 50% chance of helping to spare the ovaries. Again, whether this works sometimes often depends on the patient's age and their ovarian reserve at baseline. So if a patient was closer to menopause, um, less likely for her to retain ovarian function following treatment. Anti-hormonal therapy. So some cancers that do not directly affect ovarian function, their treatment literally requires menopause. For example, hormone receptive breast cancer. So leuprolide acetate, the trade name is Lupron, is a gonadotropin releasing hormone analog, and its effects are basically the same as natural menopause in the sense that they stop the ovaries from producing hormones. This medication is often used, especially in hormone receptor positive breast cancer. Another medication often used is tamoxifen, and tamoxifen itself can lead to early menopause in up to 48% of patients for whom it's used. Let's talk a little bit about GYN malignancies. Ovarian cancer is diagnosed in about 20,000 patients every year. Median age of diagnosis is about 63, and about 30% of patients are diagnosed at an age of 54 years or younger. Most ovarian cancers are treated with surgery and chemotherapy, a combination of both. And the surgery usually involves the removal of the uterus, the cervix, and the ovaries, fallopian tubes, and the ovaries. Some early ovarian cancers, where the cancer is confined only to one ovary, the contralateral ovary can be saved, especially for younger patients for whom early menopause could be deleterious. Um, as I mentioned earlier, standard chemotherapy is carboplatin and paclitaxel. And interestingly, despite us thinking that this is a kind of the ovaries are hormonal organs, this could be a hormonal cancer. Studies actually do support the use of estrogen-based hormone replacement therapy in patients with ovarian cancer following their oophorectomy. So there's one interesting study that was out of the UK where it randomized epithelial ovarian cancer patients to estrogen versus not. And although it did not reach its target accrual, meaning that not enough patients were recruited for the study, it saw no increase in cancer relapse. And interestingly, it actually saw that patients who were randomized to the hormone replacement group had longer overall survival than those without hormone replacement group, without hormone replacement. I think we certainly underuse hormone replacement in ovarian cancer, but there definitely is a role for it. Finally, a word on patients with a genetic predisposition to cancer, especially for patients with the BRCA1 and 2 gene. For those patients having their risk reducing surgery early, sometimes as early as 40 or even late 30s, this includes the removal of their tubes and ovaries. They are absolutely eligible for hormone replacement. In fact, for really young patients who are around 40, when I do the surgery, I discuss that I almost require them to go on HRT. That's how important I think it is for, especially for patients who are quite far from natural menopause. Endometrial cancer. Endometrial cancer is the most common GYN cancer in the US with 68,000 annual diagnoses. While the median age is 64, up a little over 20% are diagnosed before the age of 55. Treatment usually includes removal of the uterus and cervix, tubes and ovaries, and lymph node sampling. In early stage, data supports the safety of leaving the ovaries in those that are less than 50. There was a study that looked at kind of the outcomes and leaving them versus not leaving them. The risk of death was exactly the same. So it is quite safe. However, the retention of ovaries is extremely underutilized by oncologists, with actually less than 10% of patients who would be eligible for ovarian retention, having their ovaries conserved. For early endometrial cancer, especially what we call low-grade cancer, we actually can perform fertility-sparing fertility-sparing treatment with the use of progesterone, either progesterone pills or progesterone IUD, and it can be as 60 to 70% effective in entirely eradicating the cancer with about a 20% risk of recurrence. Locally recurrent endometrial cancer is often treated with radiation therapy. So for younger patients for whom we've left their ovaries in place, if they do have a cancer recurrence, often that does lead to ovarian failure. Finally, hormone replacement is safe in early endometrial cancer. This is kind of something that doesn't always make sense to patients, as we often think of endometrial cancer as estrogen driven, meaning that there's an imbalance of hormones that's causing the cancer to happen. And yet the trial that actually compared patients who received hormone replacement to those who did not showed a really low recurrence rate of endometrial cancer in both groups, concluding that HRT is safe in these patients. Cervical cancer is the most common GYN cancer worldwide. In the US, it's less common thanks to our screening guidelines, but there's still an annual case report of about 13,000 new diagnoses. The median age is a little bit younger at around 50, and 60% are under 54. So this really is a cancer of young people. Local disease is treated with a hysterectomy, usually often a radical hysterectomy, which includes often including the removal of tubes and ovaries as well as lymph nodes. A radical hysterectomy, for those who may not be familiar with it, includes the removal of the uterus and cervix, as well as the upper vagina and the tissue that surrounds the uterus called the perimetrium. There are several types of cervical cancer. The most common, the squamous cell carcinoma, actually has a very low risk of ovarian metastasis of up to 1% or even lower. And especially in younger patients, it is safe and appropriate to leave the ovaries in place. Adenocarcinoma, as a different subtype of cervical cancer, has a slightly higher risk of ovarian metastases of up to 5%. So this is a risk-benefit discussion with patients. For someone who may be significantly younger or may have contraindications to hormone therapy for other reasons, perhaps leaving their ovaries is appropriate. Those who may be older or who can have hormone replacement, for those perhaps taking out their ovaries is appropriate. Locally advanced cancer is treated with radiation therapy and still has a relatively high cure rate of up to 60%. However, as I mentioned earlier, it almost always leads to ovarian failure. So if we are curing up to 60% of our 30 and 40-year-olds of their cervical cancer, however, we are taking their ovarian function away, it is important to remember that HRT is safe and absolutely recommended in these patients. Breast cancer. Breast cancer affects up to 300,000 patients annually, while the median age of diagnosis is around 63. Almost 30% are under the age of 54. Hormone receptor positive cancer, meaning those that are ER/PR positive, may necessitate menopause for treatment. And this is where medication like leuprolide acetate are often used. Sometimes these patients are referred for surgery to have their ovaries removed. Surgical and chemical menopause, as far as efficacy for the cancer, is similar. However, some patients may prefer not to have injections and may prefer to have ovaries just removed, while others want to avoid surgery and may prefer to use the medication until natural menopause. Hormone replacement therapy after cancer diagnosis is actually somewhat controversial. There was a relatively speaking, large study done in the late 90s, early 2000s called the HABIT study, which looked at HRT following breast cancer diagnosis. And unfortunately, it was actually closed early because the recurrence rate was just significantly higher in the HRT group. However, important to note that there was actually no increase in death from the cancers. Because of the study, and the study included both patients with hormone receptor positive and hormone receptor negative cancers. Because of the study, many oncologists will shy away from prescribing or advising patients that it is acceptable to receive hormone replacement therapy, even for those without hormone receptor positive cancers. Interestingly, other studies, including randomized control studies, did not see this risk, but really this kind of given this larger study, this perception kind of persists. It's just important to remember that breast cancer is curable very often. We have a 90% cure rate in the United States. We have millions of breast cancer survivors. Many of these patients are young, and even those that may be post-menopause, many of them can benefit from HRT. So I think for a lot of patients, it is a risk-benefit discussion to weigh kind of their symptoms versus the cancer risk recurrence. Finally, chemotherapy can induce premature menopause, especially in perimenopausal patients, those that are relatively close to natural menopause. Hormone replacement therapy is often safe even in many gynecologic cancers, and possibly even in some breast cancers. Ovarian conservation is safe but underutilized in many gynecologic cancers. Ovarian transposition may help prevent premature ovarian failure after pelvic radiation therapy. I think it's important to note that in the end, the decision to whether to use the hormone replacement therapy following a cancer diagnosis is really individual, and the risk benefit should be discussed with the patient and the patient's oncologist. Quick slide of references, and as these will be posted, you guys will be able to access these articles. Thank you for your attention.
We're going to focus the next few minutes on vaginal symptoms and sexual functioning, because we have so many issues that surround that. As Dr. Stasenko said, we have so many cancer survivors, and we know that they are undertreated, underheard, and I want to present to you what are the most compelling symptoms and the most compelling issues that surround this. So we're going to talk about genitourinary syndrome of menopause, which is an umbrella term. It's really a constellation, a collection of signs and symptoms that go along with the estrogen deficiency that we alluded to. So we know women will undergo, all women, all individuals, all people with ovaries will undergo natural menopause, or if they're in the case of cancer, in the case of other situations that may arise when the ovaries are removed, or chemotherapy, a lot of other issues, radiation therapy, all the things that were mentioned, all of these things can lead to a low estrogen state. And this estrogen deficiency can really cause a constellation of physical symptoms vaginally that really reduce quality of life and reduce sexual functioning. So we have exquisitely sensitive tissues in the vagina, in the opening of the vaginal area called the introitus, the labia, the clitoris, the bladder, and the urethra. And all of these areas can be extraordinarily sensitive to this loss of estrogen. Vulvovaginal atrophy, or VVA, is an older term, and we are now use the more encompassing umbrella term of genitourinary syndrome of menopause, because we understand that it's a lot more than just the thinning of the tissues of the vulva and the vagina. Unfortunately, this is a chronic and progressive condition. This is not going to improve on its own. It will continue to worsen, and it does need some sort of intervention. So symptoms are unlikely to improve without intervention. The good news there is that there are plenty of treatments available. So we just need to allow individuals to access those treatments. Some of the most common and distressing side effects of treatment among female cancer survivors: sexual dysfunction, including sexual desire, arousal, orgasm, and pain, which we're going to talk about individually. Sometimes sexual dysfunction can impair body image and vice versa. Changes in body image can impair sexual functioning. So overall, there can be a lowered self-esteem, psychological distress, overall decreased quality of life. We mentioned bilateral oophorectomy, or removal of the ovaries. And of course, in premenopausal patients, as already mentioned, this leads to a severe, rapid, and abrupt surgical menopause. Chemotherapy, as also mentioned, can really impact sexual functioning and vaginal dryness, sexual pain, all of the things that I just mentioned. So it's important to keep that in mind. The prevalence of GSM, more than 50 million US women aged older than 52. Also, that encompasses 20 to 84% of all women who undergo natural menopause. And this is even more compelling statistically when we see women who are impacted as survivors of cancer. So it makes sense that that may start even earlier, and the percentages are even higher. In fact, over half of female patients treated for breast and genitourinary cancers report long-term negative changes in sexual functioning. And female patients treated for the GYN cancers we mentioned, up to 90% reports significant sexual dysfunction. So we know that female cancer survivors do not always receive the necessary information, the necessary support, or the treatment that they deserve for these conditions. And sometimes we just need the clinicians to ask the questions and be aware and be willing to open the discussion. Many times women will not open the discussion themselves. And we know this has a negative impact across all sexual functioning and impacts the whole overall quality of life. So that's an issue as well. The causes of GSM are any condition that results in a low estrogen state, even breastfeeding, being on oral contraceptive pills for a lengthy period of time, hypothalamic amenorrhea, which can occur due to starvation or eating disorder, premature ovarian insufficiency or failure, treatment with the gonadotropin releasing hormone agonists and antagonists that Dr. Stasenko just mentioned, and then of course ovarian surgery, chemotherapy, pelvic radiation, and then endocrine treatment, which is treatment with either aromatase inhibitors or tamoxifen. Those are collectively typically referred to as endocrine treatments. And endocrine therapy used in patients with estrogen receptor positive breast cancer, that's used to obviously to lower the risk of cancer recurrence. And they work by either blocking estrogen receptors, which is how the selective estrogen receptor modulators or tamoxifen work, or they stop estrogen production systemically, which is how aromatase inhibitors work. So the majority of breast cancer survivors will undergo this adjunctive treatment and be treated with one or other of those. And this results, particularly in the case of aromatase inhibitors, profound estrogen deficiency. And so these are commonly associated with severe vaginal dryness, dyspareunia, which is painful sex, decreased libido, and other types of sexual dysfunction. Tamoxifen appears to have less of an impact, but it does, it's less of an impact on vaginal dryness. It occurs less frequently in tamoxifen than in aromatase inhibitors, but we still know the percentages are high. In a study of breast cancer survivors receiving endocrine therapy, over 56% taking an aromatase inhibitor and 31% taking tamoxifen still reported painful sex. And the aromatase inhibitors in particular are more of a concern. What are the effects of an estrogen loss? That we have thinning of the vulvar tissues, the vagina, there's a thinning of the superficial epithelium. I have a picture that we'll look at in a moment. There's loss of vaginal rugae, which we'll talk about, narrowing of the vaginal canal and less distensibility. I think it's important to also understand what an important microbiome the vagina represents. And when estrogen is lost, there's a decrease in glycogen. And glycogen is a very important component of maintaining the vaginal microbiome. And that's because lactobacilli, which are healthy bacteria that we want in the vagina, feed off of glycogen. So when glycogen is decreased or absent, there are less lactobacilli. And without lactobacilli in the vagina, we have less lactic acid. And it's very important that the vaginal pH remain acidic. So the vagina, under normal circumstances, when it's well estrogenized, is highly acidic. And when it's not estrogenized, the vaginal pH is higher and it's alkaline. And when it's more alkaline, we have an increase in pathologic vaginal discharge and more opportunity for pathogens or bacteria to get into the vagina and cause infection, whereas glycogen, lactobacilli, lactoacid all actually improve physiologic vaginal secretions, which of course add moisture to the vagina and make sex more comfortable. Anatomically, in the urinary tract, we get the urethra moving closer to the introitus. So I'll show you a picture that will help you understand that. Right here is the opening to the vagina, the vaginal introitus, and this can actually narrow. The vaginal canal, the internal vaginal canal, can shorten, and we get a loss of elasticity overall, a thinning of vaginal tissues. And the vaginal rugae, which are structures of the vagina that are little transverse ridges that are formed out of the supporting tissues, actually contribute to elasticity, but they also increase surface area. Those tiny little outpouchings increase the surface area and provide the space necessary for the thriving of lactobacilli and a normal vaginal microbiota. So these are all of these factors work together. And if you can see here, we have the urethral meatus, we have the introitus. The urethral meatus anatomically, menopausally will move downward. And both of these tissues are very sensitive to estrogen deprivation. And that's why we see some of the urinary complaints of increase in UTI. Sometimes it's just a sensation of a UTI and not an actual UTI. And we have a lot of burning and irritation and very lack of discomfort. So it shouldn't be a surprise to anyone that sexual functioning is impacted by this. Vaginal penetration can become very uncomfortable. We see a lot of mucosal abnormalities, petechiae, which are tiny pinpoint bruises, paleness or pallor, microfissures, actual little cuts. And from the patient perspective, they feel dryness, irritation, burning, soreness, tightness, and we talked about these other factors as well. So it should be clear by now that the benefits of estrogen to vaginal health, the maintenance of blood flow, the maintenance of collagen within the epithelium. Collagen is very important. It maintains the hyaluronic acid. You think of that when you put it on your face, it adds moisture. And it maintains the pH. We talked about needing a pH that's acidic, and that keeps that healthy balance of healthy organisms in the vagina and protects from pathogens. And these receptors, as I mentioned, are located all over the tissues. This is just a good close-up view of the tissues of the vagina, and you can see the difference on the left-hand side of what a well-estrogenized vaginal tissue looks like, and the many different layers, the superficial layer, then the parabasal, the basal cells, the smooth muscle, connective tissue. All of that is very plump. It adds lubrication. And in the low estrogen state, which is on your right, you can see that there's a very thin epithelial layer. It's lacking in collagen. It's lacking in plumpness. And this is going to greatly reduce the comfort and increase friction during vaginal intercourse. The evaluation of GSM is really important. We need a complete medical history, a sexual history. We need to look at what are you doing to the vagina? You should just be washing it with warm water. I tell patients Cetaphil cleanser is okay, but you really should just wash with warm water and don't add anything to the external vagina. Don't put anything in the vagina. We need a thorough sexual history and a physical examination. We can't just assume that these vaginal complaints are just because of menopause or just because of cancer treatment. We have to take a look. There may be an indication to do cultures to check for bacteria, possibly a biopsy if there are any abnormal lesions or areas that could be lichen sclerosis or another dermatologic condition. So those are things that we need to look for and rule out before we treat. Genitourinary syndrome of menopause and sexual functioning. I think it's clear at this point how painful the intercourse could be because of the dryness and the tissue changes. Of course, lack of blood flow leads to reduced arousal. Length to orgasm can increase. The intensity of orgasm can decrease, and there can be a lot of relationship stress, frustration, low self-esteem because of this. You know, I have patients say, I just don't feel like a woman anymore. Their sexual functioning was very important to them. It was very important to their relationship. And it doesn't surprise me that all the literature has demonstrated that GSM was associated with a poor quality of life and a decrease in mental health and positive mental health. And this is even if women are sexually inactive. So it tells you how important vaginal health really is. And again, just to emphasize, untreated, this is likely to increase over time. This is a great little graphic from our friend, Dr. Cheryl Kinsberg at the Menopause Society, who's a wonderful researcher and sexual therapist. And she talks about the yin and the yang between painful intercourse and low libido and how interconnected and intertwined they are. And that painful intercourse is going to reduce libido, and then low libido is going to lead to less intercourse. And it just goes around and around and around. So we have to stop the cycle through treatment. This is very common in women, and it's associated with impaired quality of life, impaired well-being. And again, many women do not seek help for this. If their clinician does not bring this up, it may go under-discussed, under-treated. And the longer this goes on under-treated, the worse the symptoms become. One of the issues is there's no clear-cut one screener that's evidence-based for screening patients for sexual dysfunction as part of routine care, which it really should be part of routine care. And we know that sexual health and sexual well-being is a biopsychosocial phenomenon. And that means that there are many different interplays and many different factors that go into sexual functioning. And we're going to take a look at a really good graphic on that in a moment. But it just goes to show you that because it's so complex, the management pathways for sexual dysfunction need to include not just medications, but lifestyle modification, counseling, psychosexual therapy, physical therapy if appropriate, and then pharmacologic therapy as appropriate as well. So we're going to talk about some of the general categories of sexual functioning, and that is low libido or just hypoactive sexual desire disorder, just a complete lack of sex drive, which we do see in some of our naturally menopausal patients. Genital pain with sexual activity, often due to GSM. That's the biggest one that we see in our cancer survivors. And then there can be a separate freestanding sexual arousal dysfunction and orgasmic dysfunction, which I just mentioned, either diminished or delayed. And many times these are interconnected, and there are elements of all of these in a patient's history and in their presentation. We do have some checklists. I thought this one is very good. It's very short. This could be easily incorporated into clinical practice, and you can take a look at that on your own time. But it's basically just a checklist that could be done in the office, and then that would allow the clinician to specifically address the issue that comes up. The other option is for the clinician to simply use open-ended statements and to normalize the sexual functioning issue. And that might look like someone saying to the patient, many women after menopause or many women after undergoing treatment for cancer of X have concerns about sexual functioning. How about you? Or what about you? Can you tell me more about that? And use of open-ended questions really encourages the patient to open up. It makes them feel safe. It normalizes sexual functioning, and it makes us realize that it's not a big deal to talk about it. Sexual health is part of overall health, and it's very important to discuss. So really two different ways to go about it, or they can be used interchangeably. This is the biopsychosocial framework for sexual recovery that I mentioned. And it's just a really good graphic that shows how many different interplays and factors go into sexual health. And they can be biological in terms of hormones, in terms of, a change in body integrity, loss of a body part. There can be lack of sensation. If we think of breast cancer, we think of mastectomy, something that's very visible. There may be scarring. There may be a lack of nipple sensation. Lots of cancer treatments result in pain and fatigue, and pain and fatigue independently can also impact sexual health. Interpersonal relationships are also important. Low libido can often be a relationship issue, relationship discord or lack of communication, a fear of intimacy with the partner. So we need to rule out that those are an issue because those could be addressed with sexual therapist. Psychologically, a lot of emotions that surround cancer survivorship. Certainly there's a high rate of anxiety and depression. And body image issues, negative thinking. So cognitive behavior therapy can be very important and very helpful. Mindfulness-based therapies are also very helpful when it comes to sexual health. And then we have to also consider all of these factors against the background of the culture and the social factors that feed into things like religious beliefs and how comfortable people are talking about sex and being open to the discussion and to the treatment. There are treatments. The non-hormonal treatments can be effective, but they're not going to go the whole way. I'm very honest about that with patients. These are not going to change your flat estrogen. If you picture that graphic that I gave you, it's not going to change that epithelium from flat to fat. But it can go a long way in the moment of helping with dryness in the case of moisturizers. And my favorite is Hyalo-GYN, which is the last one on the list right here. And that is over the counter, inexpensive, relatively inexpensive, $25. You don't have to use anything really pricey. And that's hyaluronic acid, and that is a great moisturizer. The lubricants, the silicone-based lubricants are obviously going to last longer. They're going to be thicker, and some patients prefer those, but they can't be used with condoms or silicone-based silicone toys. But they do tend to work better and last longer than some of the water-based lubricants. So these are from the Menopause Society. These are evidence-based. Recommended lubricants and moisturizers. So it's a great resource to have. We can get a little more bang for our buck, truthfully, from hormone treatments. So when there's moderate to severe GSM, or when there's a failure of lubricants and moisturizers, then we move to the next level, which could include vaginal estrogen therapy, vaginal DHEA, oral medication, osmafene, which I feel like I never can pronounce, and occasionally systemic hormone therapy. And that for the case where we also have vasomotor symptoms or compelling overall menopausal symptoms that would be an appropriate, if the patient is an appropriate candidate for systemic hormone therapy. So that's when we would consider that. And about 50 to 60% of the time that will improve GSM, but not always. Sometimes you need to use both together. And of course, what we're going to do is we're always going to work in conjunction with our GYN oncologists when we prescribe any kind of vaginal hormone, or certainly with a systemic hormone. So we have vaginal creams, inserts, rings, and oral tablets, which I mentioned. And one of the biggest problems that I see with this is oftentimes patients will come to me and they'll say, yeah, I tried the tablet or I tried the cream and I used it for a little while. It didn't work for me. I stopped using it. It was a pain. I didn't want to use it. And 90% of the time, it's because they were using it inappropriately. Maybe no one took the time to explain. The vagina does not re-estrogenize easily. You need to use the cream or the insert or the ring. The creams and the inserts in particular need to be used every night for 14 nights in order to reestablish and re-estrogenize the tissue. And then after that, they need to be used reliably 2 to 3 times per week. So the doses may vary. The cream is what I prefer because it coats the walls of the vagina very well, and you can take a fingertip application of the cream and put it on the opening of the vaginal introitus and on the urethra. And that really is very, very helpful in reducing friction and applying moisture and rejuvenating those tissues. The tablets just go in the vagina. They're going to melt and coat the walls to a certain extent, but they're not going to do anything for the external structures. So I think that is an important advantage of the vaginal cream. The vaginal ring works great. It's very easy. It's inserted and then replaced every 3 months. It's expensive, sometimes hard to get approval for, but I think it's a great option. We'll talk about prosterone in a minute, which is DHEA, and that is a vaginal suppository. And it's indicated for moderate to severe dyspareunia, painful intercourse. and it does show significant improvement in 3 different randomized controlled trials. And still the serum steroid levels remain within the normal postmenopausal range. And I want to talk about that for a minute, because we want to understand that all of these treatments are not going to elevate estrogen levels beyond the postmenopausal range. And we're going to talk about that in a moment. Treatment for with fractional CO2 lasers, which you may have heard a lot about. They come under different names, Mona Lisa and other different terms. And those have been studied for the treatment of GSM. It's obviously non-hormonal, non-pharmacologic, so it's very appealing from that standpoint. There have been several small open label studies that have shown efficacy. So we do get some increase in vaginal symptom scores, sexual function scores, and there are trials comparing laser therapy to low dose vaginal estrogen, which are ongoing. I think that's going to be interesting to see those results. And so it's costly, and we don't know what the long-term effects might be, but for patients who have failed other therapies or cannot use estrogen of any kind, this could be an option that might be worthwhile. And then pelvic floor physical therapy, I think, is very underutilized and extraordinarily important. So stimulation with pelvic floor physical therapy with a trained physical therapist is really important. And they can use biofeedback, electrostimulation, myofascial release. And myofascial release in particular is important for high tone pelvic floor dysfunction, where the muscles are too tight, and that can help be released so that sexual intercourse can be more comfortable. Vaginal dilators can be super helpful. I send a lot of patients for that therapy, and that helps stretch the muscles and mechanically stretch the vagina. For patients that I see who have just let it go on too long, they sometimes need that to open up the vagina and stretch it a little bit, and they can use graduated dilators. So there are people that are extraordinarily well-trained pelvic floor physical therapists that specialize in this. We have them at NYU, and they're wonderful. And I certainly think this is something that more people should be referred for. Sex therapy, we mentioned, it is really focuses on the overall issues that are related to sexual functioning, intimacy. They are licensed therapists trained in sexual health and relationship dynamics. And it's talk-based, but it also provides educational guidance and behavior-based interventions. And usually the focus is on mindfulness-based approaches at enhancing desire. So this can be super helpful for either relationship discord or people with hypoactive sexual desire disorder, otherwise known as just low libido. We have some pharmacologic treatments for premenopausal women for low libido, but I'm only going to speak of one of them because only one has been evaluated in particular in breast cancer survivors. That's fulbanserin. And there was a small pilot trial of 20 women with ER-positive, estrogen receptor-positive breast cancer, and they had low libido, and there was an increase using this it's not terribly, it's not gonna knock your socks off, but it went from 0 to 2.2 satisfying sexual events per month. And we use standardized scales to look at improving sexual desire and decreasing sexual distress. And now there's a larger phase 2 trial that's ongoing, and we're looking at quality of life in breast cancer survivors and seeing if it can help minimize hypoactive sexual desire disorder. And we really need larger randomized placebo-controlled trials. We just do not have enough options for women suffering from low libido. And we know that, and it's an area of ongoing research. So this is just a little bit more about fulbanserin, otherwise known as ADI, and it's a non-hormonal. It gives you the mechanism of action, and there is the downside of it. I'm not like, it doesn't knock your socks off. The 2.2 increase of 2.2 satisfying sexual events in a month. However, the other downside of it is the side effect profile. So it increases dizziness, drowsiness. It can have a low blood pressure, even fainting. And there's an increased risk if you drink alcohol with it. So we have to be really careful with that. So I think I'll end with the idea that patients should be provided to access with a multidisciplinary treatment team. The biopsychosocial model is so important, and having a place like NYU, which is an area of a research center, a major university medical center with tremendous providers available. We really want to work on creating a team that can include a GYN provider with expertise in managing menopause, a psychosocial or a mental health provider and/or sex therapist, and of course, pelvic floor physical therapist, all of whom should have a subspecialty in working with cancer survivors. So I'm going to end there, and I'm going to thank you very much for listening, and I hope that was helpful, and we can take a few questions now. I think we discussed the genitourinary syndrome of menopause. So the loss of estrogen leads to the lack of estrogen in the vaginal tissues. And therefore, what we have is a situation where we get into the vicious cycle of very painful intercourse or dyspareunia, and that can feed into itself and make a lower libido because an individual does not seek out sex or want sex if it's painful. So that can be an easier fix. Fixing the pain can often increase the desire to have sex.
It is vital to use some sort of vaginal dilator while following radiation therapy. We often will recommend an actual dilator. They come in various sizes and can be purchased from different groups, different companies, but often our radiation therapist will provide our patients with the dilator. The general thought and kind of how I counsel my patients is either vaginal penile intercourse or a dilator regularly. For my patients who are very reluctant, and then they tell me, well, I'm not having sex. That's fine. I'm old. First of all, it hurts my heart. But second of all, it's actually more than just vaginal penetration. It's actually a part of a physical exam. So if I can't do a physical exam because radiation changes to the vagina can cause shortening or even sometimes completely closing off of the vaginal canal, I can't diagnose cancer recurrences early. So for multitude reasons, one, so that the vagina maintains its length for use in sexual function, but also so the vagina maintains its length for physical exams. Use of dilators following radiation therapy is a really important part of survivorship. The thing to remember is a lot of the chemotherapy agents that we use that I mentioned are not just used in ovarian of GYN or breast cancer. They're used in a multitude of cancers, colorectal cancer in particular. So it's not so much that these drugs are specific to our cancers, and by our cancers I mean GYN cancers. That's my specialty, but more that these drugs can cause ovarian suppression or even potentially ovarian failure. So anyone undergoing cancer therapy with a chemotherapy drug is at risk for either premature ovarian failure or kind of side effects from the medication use. So really, it can affect anyone undergoing therapy for any cancer when they're using chemo agents. Yes to both. Mm-hmm. Yes, absolutely. Vaginal dryness can lead to bleeding. But yes, you should also have let your doctor know that you are having bleeding, because that is certainly a reason for an exam. I think I wanted to chime in, and I'm not sure we covered very much of this, but there are, for patients who for whom hormone therapy is contraindicated, who are having symptoms of that are maybe hot flashes or vaginal dryness, Laurie definitely covered some of the vaginal moisturizers, but there are other medications we can use for things like hot flashes and vasomotor symptoms. So it is absolutely worth your time to speak to your doctor, whether it is your oncologist, whether it's your GYN, about your symptoms, because there are definitely things that we can offer that may not eradicate your symptoms, but can definitely help.
When we see a patient in the menopause center, we go over, hormonal options and non-hormonal options. And for cancer survivors, we usually focus on the non-hormonal options. And the good news there is there are plenty of systemic non-hormonal options that are evidence-based, that we feel very safe using, that are very effective.